Dr. Joan Asarnow's Family Intervention for Suicide Prevention was built upon the work of Dr. Jane Rotheram-Borus, who developed a program to identify children in imminent danger for suicide. Dr. Asarnow's intervention is targeted to help families of children and adolescents who present to an emergency room with suicidal ideation or after a suicide attempt. Colleague Dr. Maggie Rea is helping to disseminate the intervention into community and county mental health settings.
Well, in this world, one person dies by suicide every 40 seconds. Over 100 people die of suicide in our country every day.
About 12% of girls will try to kill themselves, less than 1% of boys. It varies by ethnic group, so more Latino adolescent girls, even though they're far less likely to try suicide, boys are far more likely to succeed.
And I think what's exciting about this model is that it was developed in the emergency department and had some exciting outcomes with it. But what I found very exciting is that it's very portable.
We wanted to do something that was useful in the emergency room. We wanted to do something more than assessment. We wanted to provide a treatment in the ER that would make a difference.
What sparked your interest to address the problem of youth suicide?
I was working originally in the inpatient unit here at UCLA, and one of the most common problems that we had were kids who came in because of a suicide attempt. And most of those kids had come in through the emergency room and described their experiences to me. And I could see that it was very important that we intervene effectively in the emergency room in a way that really used the emergency room visit as a window of opportunity to do something that would make a difference, that would help gather families together around their child and help their child to accept help from their families. And that was a moment when I felt that could happen in ways that maybe couldn't be done as easily after the emergency room visit because it was so emotional for so many families. So I looked to see what had been done. And that's always the first thing you do, right? You look and you see what other people have done because we all stand on the shoulders of the wonderful people who come before us. And my colleague, Jane Rotheram, had developed this wonderful intervention, I thought, that did exactly that.
In the late 1980s, Dr. Rotheram-Borus and John Bradley developed a triage model in New York City to identify runaway youth who were at risk for suicide. Out of their work, a training manual, Evaluation of Imminent Danger for Suicide, was published by the National Resource Center for Youth Services. This formed the basis for Dr. Asarnow's intervention.
In the late 1980s, I was working in homeless shelters, and in one 3-month period, 12 suicide attempts occurred in 2 New York City shelters. And at that time, we ended up making a systemic intervention that, one, figured out a way, how do we distinguish, especially when you have kids at very, very high risk for a lot of negative outcomes, how do you distinguish who's truly suicidal today versus who might be at risk for suicide in the next 4 years, but maybe not today? One, how are we going to get them in the emergency room? How are we going to get those youth to actually follow up and get mental health treatment? And then if we're going to intervene with them and provide treatment, what are we going to do? So we created a behavioral challenge. Could you engage in activities that are inconsistent with being suicidal? Can you tell me good things about yourself? Can you tell me what would you do when you feel suicidal? It wasn't a large study, but it demonstrated that from 12 and 3 months, we had 1 suicide attempt in the next year in these shelters. And youth who were at high risk were triaged much earlier into emergency rooms.
What are the components of the intervention?
We had 3 components that really addressed different aspects of difficulties and tensions in treating kids who come into the emergency room for suicidality.
Family Intervention for Suicide Prevention components. 1. Emergency Department training. 2. crisis therapy session designed to provide a behavioral assessment of current risk and offer an intervention that will increase safety and enhance motivation to pursue follow-up treatment. 3. Telephone contacts to support families in linking to follow-up care after leaving the emergency department or hospital.
Emergency room doctors and nurses and other staff in the emergency room have very little training oftentimes in mental health in general and in suicide prevention in particular. So we began the intervention by preparing the emergency room in a way that would support improved care and an enhanced mental health intervention in the emergency room. And that involved providing education to the doctors and nurses and other staff, including the security guards and check-in folk in the emergency room, about the needs of patients who were coming in with suicidal concerns and how they could be part of a suicide prevention effort. So normally a suicidal patient is evaluated medically, and when they're clear medically, then they're seen by someone for mental health evaluation, but we wanted to come in and actually deliver a treatment, and our treatment is designed to also provide a behavioral assessment of imminent risk so that it can help in making the decision about who's safe to go home and get follow-up treatment and who needs to go into the hospital for further evaluation. So we deliver a crisis therapy session in the emergency room. It could take anywhere between a half hour to an hour and a half, depending on how much time there is. Then the final component is to provide contact after the emergency room visit to ensure and motivate and help patients and families to get to needed outpatient treatment after the emergency room. That was the primary goal of the intervention, because you can only do so much in the emergency room. But what we want to do in the emergency room is to give people an experience that will give them some help in staying safe, and will also give them a taste of what a mental health intervention feels like. And that helps to decrease barriers, I think, both in terms of motivating people to want to pursue treatment, and also in terms of maybe not being so frightened of what mental health treatment might involve, and seeing what it does involve, as well as motivating them to get that treatment. We know that about half of kids nationally do not get any follow-up treatment after discharge from the emergency room for suicidal behavior, and that's a really big problem. Our rates are as low as 20% in some ERs, which is very, very alarming. So it's a big enough problem that increasing continuity of care after discharge from the emergency department or the hospital is a major objective of our national strategy for suicide prevention.
How successful has the intervention been?
Well, there's some really good news. Our national strategy for suicide prevention emphasizes the importance of getting people care for suicidal behavior after an acute suicidal episode and an intensive care episode, like the emergency department or inpatient hospitalizations. And we have treatments, in fact, this treatment is one of them, that's very, very effective in getting kids to outpatient treatment after discharge from the emergency room. Nearly everybody got there, over 90%. The not so good news in that story is if kids get community treatment as usual after the emergency department, there doesn't seem to be a longer-term impact on clinical outcomes. So if you look at kids 2 months after being discharged or 1 year after being discharged, we're not seeing differences in clinical outcomes. So what that really does underscore is the importance of follow-up treatment that is evidence-based and evidence-informed after kids are discharged from the ER or hospital. And we have data showing that when you provide the emergency room intervention plus evidence-informed follow-up treatment, as in the case of, in ours, we're using an intervention called the safety intervention, where the ER intervention, the family intervention for suicide prevention, is used as the first session in an outpatient treatment. We're seeing real improvements in outcome after that. And in Dr. Rotheram's earlier study, she found that when combined with a structured family intervention, they had improvements in clinical outcomes. So you really, really do have to both get kids to needed follow-up care and deliver an evidence-informed intervention. And the good news is that we are having more and more interventions that are looking like they're making a difference.
Why is the emergency room the right setting for this intervention?
Well, it is an important place because that's where kids come who have made the most dangerous suicide attempts. And so doing something at that moment when people are raw and they're hurting and parents are in shock, doing something that is helpful in that moment is very important, as opposed to something that's unhelpful. But given that our potentially most lethal kids are coming into the emergency room, we need to do something there that makes a difference. Otherwise, we're going to have more deaths. And our suicide rates are not going down. They've been increasing. In the past 15 years, we've seen a big increase in suicide rates. In girls aged 10 to 14, we've seen a tripling of the suicide rate. So we really do need to change what we're doing in emergency rooms and elsewhere so that we do prevent suicides. It's something that's very important.
How do you approach children in the emergency room?
We begin by trying to change the rhythm of the situation. So we go in and say to the child, "This has been a really rough day, and you don't know me. So why don't we start by you just sharing with me something that you'd like to tell me about yourself, something that you're proud of, something that you feel good about, something that would give me a sense of who you are as a person." The second part of what we do is we bring out this tool to help kids to begin to understand emotional responses. They're there, something has happened, that's led to them feeling like they want to give up, they've attempted suicide. Sometimes they really, really, really want to die. Most of the time, they're not sure. So we help them to understand their emotions in the situation using this emotional thermometer tool. And then where on the emotional thermometer do they start to get to the point where their emotions are escalating and getting so hot that they're going to lose control and potentially do something unsafe? And what could be done at that point in time to really focus on bringing their emotions down to a level where the child's in control as opposed to the emotions. And then we would work with them to develop a safety plan to downregulate those emotions when they started to get intense.
What I love to watch is how much it empowers clinicians because they have some tools to use in these potentially high-risk situations. And they have tools that they can both empower the kids, but also the families who are struggling with what to do when they have a child that is suffering and who is potentially at risk.
What about the issue of fidelity as the intervention is used by health providers in other settings?
I think fidelity is a huge challenge. And, Dr. Asarnow and myself have worked hard to try to identify a way to track, the implementation of the model to assure fidelity, we have gone back and forth about everything from, audio taping, tracking outcomes with whatever particular site that we're at. And I think it's definitely a work in progress because all of us who have worked in the area of implementation of evidence-based practices into real-world settings, it's probably the place we've all fallen down. And part of it is trying to get the particular site agency, for lack of a better word, to buy in to the importance of continuing to implement ways so they can track the adherence to a model. Because after we leave and we do the training, 6 months later, what's happening with those clinicians. Are they doing the model? Are they doing it well? And are they starting to disseminate on their own? So for example, that brings in one of the things that we're working on, which is helping agencies, train the trainer. So working with agencies to create their own in-house trainer and champion for the model, because we feel like only with that, where there's someone who is on that fidelity, after we sort of somehow, we extricate or we step back, we want to be sure there is someone who's a in-house trainer, and really we like the word champion of the model, so it can continue to be done well and with fidelity.
Can this intervention be used in other settings beside the emergency room?
I don't think the emergency room is the only place that we have to intervene. I think we need whole health systems to really mobilize around the aspirational goal of zero suicide, and health contacts that people have with their primary care provider, with usual providers, are sensitive to mental health issues and really step in at times before kids get to the point where they end up in the emergency room. But given that our potentially most lethal kids are coming into the emergency room, we need to do something there that makes a difference.
It's very portable. It's an intervention that, grew in the emergency department, but a lot of my job is porting it, carrying it, and integrating it into other settings. It's figuring out what they need, but also how would it work, even from the basic, how are we going to train you? What is the training going to look like? Because we want to be very sort of adherent to the model about what we provide, but we also want to be flexible about recognizing that different, settings have different needs and different logistics.
What are the pathways that lead to suicide for teens and children?
We know that the pathway to suicide and to suicidal behavior is complex. It's also heterogeneous. It's very different for different people. I don't think I've ever met anyone where it's the same thing. There are certain commonalities that you really need to focus on for everybody.
Geography is destiny. There are some settings for which there's few opportunities and pathways both to get early intervention or to get pathways out of risk.
What role has the internet played in suicidality among teens?
Well, the internet has so many wonderful things about it. We can get information so quickly. It's very hard to monitor what kids are being exposed to on the internet. They're learning about suicide on the internet. There have been incidents of people showing suicides on the internet. Kids are bullied on the internet in a way that's much more personal. It's a very complicated question.
What can be done for those children who don't have intact families to help support them?
You really have to create a family around the child, and that family might involve a social worker who's working with the child. It might involve a neighbor. It might involve a more distant relative. You have to create somebody, because kids can't do it alone. And particularly a child who's struggling to the point at which they turn to suicide, they need to have a responsible adult to turn to.
What challenges need to be addressed in the future?
Young people who succeed and do kill themselves, if you call that a success, are those that have a long and progressive history of mental health problems.
By reaching out to kids and parents, I think you can strengthen support of everybody and strengthen the ability to respond to stress. And we have some data that suggests that if you provide interventions like our emergency family intervention for suicide prevention in combination with more intensive outpatient care in the community, kids actually have better outcomes than if you put them in the hospital.
Our next challenge is going to be to partner with large health systems and to diffuse these kind of strategies as usual care, standard care, in primary healthcare settings.
So that we really are attentive to these kinds of risk behaviors, and we can intervene before they get to the emergency room. And we develop our whole health systems so that we move towards zero suicide.
There's a lot of initiatives towards this at the federal level, Every state is considering what they're going to do. Some states are substantially farther ahead than others. Utah's child system, Wisconsin's child system have integrated mental health care as standard practice into primary health care. California has a way to go, and most states have a long way to go. And integrating primary health care and mental health care into the same office, and either with professional or paraprofessional providers, is going to be our next challenge.
We can get almost everybody to outpatient care if we deliver an effective intervention in the emergency department or in an emergency crisis situation, because that intervention can be delivered in outpatient settings. We're doing it now. It can be delivered in schools. It could be delivered anywhere where you find a kid who's in an acute suicidal crisis.
If we don't have ways to outreach and to follow up over time, young people who have demonstrated their willingness to try to end their life will never reach zero suicide.
What have you learned along the way developing this intervention?
One of the things I've learned from the families and from the kids, because we did a lot of interviewing of kids and families as we were developing the interventions, around what did make a difference for them when they were suicidal, what got them through the moment, is the importance of their families. And the interventions, I think, that really make a difference are the ones that help give kids a reason for living and help them build a life that they want to live, and help them find ways that in the moment when they feel like they're done and they can't take it anymore, instead of turning to a rope and creating a noose or taking a big bottle of pills or some other potentially lethal method, they turn to mom or dad or some trusted person for help. And that's often enough to get you through the moment. And what we need is some way of getting kids through the moment. And hopefully what we're doing is we're building protective factors that are protecting our kids and making them more resilient to the stresses that are hitting them, and we need to do that.